With these words, now I request Dr. Rupak Singla, who is the head of the department TB and chest at our institute, to give his didactic for the day, which is where we are discussing certain cases which we come across in the field. And as per new guidelines, these cases need to be managed, a regime has to be made for these patients. So we are taking case studies today. Welcome, Dr. Rupak Singla.
Thank you, Dr. Neeta. At the outset, I would like to thank all my respected teachers, respected seniors, my dear colleagues, and the students who have spared time to join us today. You know, the science is ever changing. So, as the new evidence comes, we have to revise our guidelines. And in March 2021, the new guidelines were released. And as you know, in the last clinic, we discussed what have been the major changes in these guidelines compared to the older guidelines. And today, in the continuity of the same thing, our seniors, they suggested that why don't we take up some case studies through which we'll discuss that now, as of today, as per the new guidelines, how should we treat a patient. So this is the result of the same suggestion by our seniors that we are discussing today, a few of the case studies. And these are the case studies which we often see in our practice. And they are the actual cases which were reported over institute. I hope things will be clarified once we see these cases. So with this background, I will go for the first case, please. Just okay. So before that, you see the basic. I would like to spend some time in a single slide on the basic principle of managing a DRTB case or DRTB patients. Most important point is that we need to prevent the development of drug resistant TB by appropriate management of drug sensitive TB. This is very, very vital. In case we treat them well, then the chances of patient moving towards drug resistant TB will be minimized. We must take a detailed history, including the contact with a confirmed DRTB patient and his or her intake of the anti-TB drugs, and also correlate the laboratory reports of the DST to the drugs used and drug not used by the patient who has come. And also we need to know, you see, sometimes the report comes and without even attributing it whether it's from a certified lab or not, we just blindly take a call for treating the patient based on the DST of the patient. So here also we need to know it must be from a certified lab, and we also need to know which are the drugs against which the lab report is very reliable and against which drugs no, we need to take it with a pinch of salt. So here, as far as the phenotypic DST is concerned, it is reliable and reproducible for rifampicin, INH, oxyfloxacin, levofloxacin, and the second line injectable drugs, that is micacin, kanamycin. Then the quality assured phenotypic DST is available for pyrazinamide and linezolid. So again, if we have a report against these from a certified lab, we can take clinical action based on this. Now we also should know that phenotypic DST is inaccurate and not reproducible for drugs like ethambutol and ethionamide. So please keep in mind, and there is no agreed DST method established for drugs like cycloserine, CAS, imipinine, celastatin, and meropenem. So if you take into account these facts also, it will be easy for you to take a treatment call for a given patient. Now with this we come to the first case. This was a 39-year-old male complaining of fever and cough for 6 months. Looking at the history of drug intake from January 21 to March 21, based on a positive sputum report of he was diagnosed as pulmonary TB. He was given the first line drugs, all the four as per our national guidelines. Patient did not improve. At the end of 2 months, sputum smear was 3+ positive when he was referred to us. Sputum for first line LPA showed INH high level resistance, rifampicin sensitive, and the second line LPA showed fluoroquinolone resistance and injectable second line injectables sensitive. And sputum for midget culture was awaited at that time. Then you can see the X-ray of 2020 of January 21 and March 21. There is a definitely deterioration in the X-ray. So there is a clinical deterioration, there is a radiological deterioration, and at the end of 2 months, patient is still sputum 3 plus positive and found to be resistant to INH while sensitive to rifampicin. So let us see, you see, very, very important point is, although yes, we are clinician, but now with the genotypic test coming in the picture, we must know some basic things of how to interpret a mutation analysis so that that will help us in treating a patient appropriately. Regarding INH, we have two types of mutation, CATG and INHA. If the CATG mutation is present, then it indicates that INH high level resistance is there. In case INHA mutation is absent, so second mutation is INH. In case it is absent, that means ethionamide can be given. If it is present, ethionamide cannot be given. For rifampicin, it is a mutation in RPOB gene. If it is present, it is rifampicin resistant. If it is absent, that means rifampicin is like in. Regarding fluoroquinolone, in case in gyre, mute 1, 2 or 3A is present, that means fluoroquinolones are resistant. However, in case mute 3B, 3C and 3D, all the three are absent, then we say although fluoroquinolone is resistant, but moxifloxacin high dose can be given, although we need to reconfirm it by the culture DST reports. Regarding second injectables, there are two kinds of mutation, RRS and EIS. If both are absent, that means all the injectables can be given. If only EIS mutation is present but RRS mutation is absent, that means kanamycin cannot be given but amikacin can be given. So you see, by looking at these mutations, we know which drugs we can give to the patient, which drugs we cannot give to the patient, and you know these mutation reports are available, ideally available within 10 to 12 days. But unfortunately, let me reiterate here that in the field what we are seeing is that samples are sent to the laboratory, and sometimes there are delays at the laboratory level. Sometimes they do their job well and they upload the report on the Nexus system, and the DTO team, DTO and his team, which includes STS, STLS, DRDB, supervisor, etc., they are not taking an action on this. And unfortunately, very commonly we are having cases where the action was not taken up to 2 months, 3 months, 4 months. So what will happen that in these 2-3 months, patient will be on a wrong regimen, which can lead to resistance to the drugs. I'll come to that. So this we have to prevent. So the diagnosis in our case is DSTP treated case for 2 months. End of IP is H high level resistance with rifampicin sensitive. He has fluoroquinolone resistance, moxifloxacin high dose can be given, and DHT2 pyrazinamide is not known. So since these are rifampicin sensitive, only INH resistance along with fluoroquinolone. In this case, what we'll consider is what regimen will be? It will be H monopoly DRTP. So let us just briefly discuss about this regimen and the duration. Usual duration is 6 months, and the drugs are levofloxacin, rifampicin, ethambutol, and pyrazinamide. However, we should know that the duration can be extended till 9 months in patient with extensive disease, in patient with uncontrolled comorbidity, in extrapulmonary tuberculosis. If the smear at the end of 4 months or culture at the end of 3rd month is found to be positive, again we'll have to extend the period. Or if we have to give any replacement of any drug in the regimen. In this situation also, we have to extend the duration to from 6 months to 9 months. In conditions like CNS TB, skeletal TB, and miliary TB, here we may have to give the treatment for 1 year. So again, you see, we should extend only when it is indicated. There are issues related to the DBT also, and many DTO friends they complain that just unnecessarily the treatment is being extended. That should also be avoided. So when we say the word extensive disease, we need to extend this. So here we know that now in 2021 guidelines it has been defined. In adults, the extensive TB is bilateral extensive disease or extensive parenchymal damage on the chest radiography. While in children less than 15 years of age, presence of cavities, whether unilateral, bilateral, this will be extensive disease, or bilateral disease on chest radiography. This will be taken as a extensive. So let us come back to this case, and before that, just briefly about the sequence of replacement of the H monopoly regimen. If we cannot give levofloxacin, then we replace levofloxacin with moxi high dose. If the second LPA tells us that mute 3B, 3C, 3D are absent, that means we can give moxifloxacin high dose. But simultaneously, we should send the sputum for liquid culture DST for detection of resistance against moxi high dose as well as pyrazinamide. Now, If moxie high dose of pyrazinamide cannot be used because of the resistance, we replace with linezolid in the regimen. If linezolid also cannot be given, we replace with clofazimine and cyclosporine. On the other hand, if both moxihydrose and pyrazinamide cannot be used, in that case, we have to have two drugs of the three, that is in this series, the linezolid, clofazimine, cyclosporine, in that order of preference. So in our case, we initially planned for 6 months of levofloxacin REZ, but because we have fluoroquinolone resistance and in the guide with 3B, 3C, 3D are absent, that means we can use moxifloxacin high dose instead of the levofloxacin. So what will happen in our regimen? We replace levofloxacin by moxi high dose and the duration will become 9 months. So the final regimen in our case will be, instead of levofloxacin, we give moxi high dose, rifampicin, pyrazinamide, ethambutol for a total duration of 9 months. Now, in the same scenario, we can have, if the second LP shows MUT3C is present. So as we discussed, a MUT3B, 3C or 3D, any one of them is present, that means even high dose moxi cannot be given, it is likely to be resistant. So what will we do? In this case, we replace levofloxacin or moxi high dose by linezolid, as we discussed, and duration again becomes 9 months. And the regimen will be linezolid in place of the quinolones or moxi high dose. Rest of the drugs remain same, rifampicin, pyrazinamide, ethambutol for a total duration of 9. There can be another scenario where second LP shows MUT3C present and DST from a reliable lab is showing Z is also raised. So in this case, what will we do? We have two drugs of the three, linezolid, clofazimine, cyclosporine in that order of preference. That is linezolid and clofazimine in this case, and duration will become 9 months. So the regimen will be, even Z cannot be given, so it will be linezolid, clofazimine, rifampicin, ethambutol for 9 months. So I hope through this case, it is clear that how to make a regimen for a H monopoly and how to go for the replacements. Now let us go for case number 2. So this was a 15-year-old female who came with fever and cough for 9 months. When we look at the treatment history, from March 19 to July 19, she was sputum, at the beginning she was sputum positive. During this period, she received the first 4-line drugs from a private center, from a private clinic. It was irregular, so she received for 4 months and then after that defaulted. Now we got it as loss to follow. Then again in July 20 till April 21, for 9 months, at the beginning she was sputum smear positive. She was given 5 drugs including cefpromycin. She was regular, but she failed to treat. And subsequently, she came to us. Sputum was 2+. When she came to us, first LP showed H high level resistance, rifampicin resistance, so MDR. And second LP showed fluoroquinolone sensitive and second injectable sensitive. And the sputum formation was abated. So this was the X-ray. You can see there is a lesion in the right mid zone and lower zone, and it's always like a cavity disease with maybe there is some fungal ball inside. So again, going back to the mutation analysis, for INH, CADG mutation was present, INH mutation was absent. So we could give isoniamide, but high dose INH was resistant because of the CADG mutation being present. Regarding rifampicin, RP mutation was present, so indicating rifampicin resistance. For fluoroquinolone, in Guide A and Guide B, all wild strains were present and mute strains were absent, indicating fluoroquinolones are sensitive. Regarding second injectables, we found RRS mutation as well as EIS mutation, they were absent, indicating all the 3 second-line injectables can be given. So the diagnosis was 15-year-old retreatment case of pulmonary TB who had MDR TB because he had H as well as RIF resistance, with RIF resistance and H high level resistance and no fluoroquinolone or second-line injectable resistance. So what regimen? Next question is, with this background, what regimen we should give? So now before we go, let me take you through the principles of making a regimen in any case. Whenever we are dealing with a case of drug resistance TB, what should be the basic principles? Step 1 is we take the detailed history of drugs which patient has taken and detailed history of drugs which patient has not taken. Very important. Second is we look at the DST. So we will have 3 kinds of reports. So DST showing drugs which are sensitive, DST showing drugs which are resistant, and DST to certain drugs will not be available or it may be awaited. So the first preference of drugs will be the drugs which have not been used and DST is showing sensitivity, especially from a certified lab, they should be chosen first. Second preference is drugs have not been used but the DST is unavailable at that time or is awaited. So they should be the second preference of drugs in this. The third preference should be the drugs have been used but laboratory is saying they are sensitive. This should be the third preference. If drugs have been used and DST is not available or awaited, this should be the last preference for us in treating the patient. The fifth preference could be drugs if you are cornered. Drugs have not been used but DST showing resistance. Better is to avoid them. Only when we are cornered, we may consider them for a given case. Otherwise, better is to avoid them. They are unlikely to be effective. And the last thing is which are not to be given is drugs have been used also and the DST showing resistance. Here, never give these drugs. You are unnecessarily spending the money of the patient. You are leading to the reverse drug reaction and you are augmenting the resistance to these drugs. So it is to be not to be given. And even this fifth choice is better to be avoided. So first preference this, and second, then third, then fourth. So let us put our case in the same principles. So drugs taken by the patient, all the first line drugs including streptomycin. Drugs not taken by the patient are all the second line drugs including the newer drugs the patient has not taken. DST showing drug sensitivity, that is fluoroquinolones are sensitive, injections are sensitive, zonomide is sensitive. DST showing drugs are resistant at H high level and rifampicin, and the rest of the drugs, including newer drugs, bedaquiline, delamanine, the DST is awaited. Here, let me tell you, at least two of the laboratories, that is our institute, NITRD and NIRT Chennai, they are already started doing bedaquiline and delamanine, and the CTD is trying to expand this to the other laboratories and other national. So drugs not used and DST showing sensitivity. They are second-hand injectables, fluoroquinolone and ethanol. Drugs not used by the patient and DST is either not available or is awaited to all other second-line drugs, including the newer drugs. Drugs used by the patient but DST showing sensitivity, nil. Drugs used by the patient but DST is awaited or not available, that is pyrazinamide and ethambutol. And under the program, because ethambutol DST is not reliable, so under program, ethambutol we are not doing, but yes, pyrazinamide we are doing. That was awaited at the time when we were supposed to take a call for the treatment. Drugs not used but DST is showing resistance, nil. Drugs used and DST showing resistance are INH and rifampicin. So by looking at the drugs taken, not taken and the DST, we have reached to this level, and from these we have to make a judgment. So as you know, under our national program also in the new guideline, whenever we have rifampicin resistance detected, our first preference goes toward the shorter regimen unless it is contraindicated. So we go down the line, we look for any exclusion criteria, and we find in this case, if there is no additional resistance, like suppose to fluoroquinolone, H resistance is there, but with either CAT-G or INHA only, not both. And FQ resistance is not there. You see, there is a change in the newer guideline. Earlier, even INHA mutation was a contraindication for use of shorter regimen. But now, with experience from South Africa, where it was observed by the national experts that even with INHA alone or CAT-G alone, they had good results. So, our country has taken a call in the new guidelines that if there is INHA mutation or CAT-G mutation alone, then we can give. But in case there is a mutation to both of these drugs, then shorter regimen is contraindicated. So, in this case, shorter oral bedaquiline containing regimen is likely to be effective. So, that should be our first choice. Now, whenever we choose shorter oral bedaquiline containing regimen, very important is that we should see the inclusion criteria and the exclusion criteria very carefully before choosing the shorter regimen. So, what are the inclusion criteria? Which are the patients who can be included? They should have rifampicin resistance or MDR-TB without any fluoroquinolone resistance. If fluoroquinolone resistance is there, they should not be given shorter oral bedaquiline containing. Then, as we discussed, presence of only INHA or only CAT-G but not both. If both are there, they should not be given shorter regimen. Then they should not have any extensive pulmonary TB disease. As we discussed, what is extensive PTB? then we can give shorter oral bedaquiline containing regimen in all extrapulmonary TB except disseminated TB, CNS TB, biliary TB, and meningitis. So except these conditions, in all extrapulmonary TB, we can give shorter oral bedaquiline containing. It can be given to children more than 5 years of age because now in the new guidelines, why 5 years is because now bedaquiline can be given up to 5 years of age of children. PLHIV, yes, it can be given to all PLHIV unless there is extensive PTB or there is extrapulmonary TB which is severe in the form of CNS TB, biliary TB, meningitis. If you remember in the old guidelines, any PLHIV with any of the extrapulmonary TB was contraindicated for the injection containing shorter regimen. Now in the new guideline, in PLHIV with the EPTB, we can give shorter regimen other than those having disseminated TB, CNS TB, biliary TB, or meningitis. If a patient has used more than 1 month of drugs like bedaquiline, levofloxacin, isoniazid, or clofazimine, these are part of the shorter regimen, and they have demonstrated DST which is sensitive to these drugs, we can give. In case patient doesn't have a report or is having a report which is resistant, then we should not be giving the shorter oral bedaquiline containing. So very important is that we should choose very carefully which are the patients where we can give shorter oral bedaquiline containing regimen. Otherwise, in case you give it to a wrong patient, they can lead to rashes against these good drugs. Exclusion criteria, which are almost mentioned above, or some new one, like pregnancy and lactation, subjective condition. When I say subjective condition, in pregnancy, the injection containing or regimen is totally contraindicated, but the bedaquiline containing oral shorter regimen can be given provided the pregnancy is more than 32 weeks, because now more than 32 weeks only we can give it Spanamide. Less than 32 weeks we cannot give it. Okay? And even after more than 32 weeks of pregnancy, it has to be a consultative decision between the patient, chest physician, and the gynecologist. Patient should be told the risk and benefit of giving bedaquiline in these cases. If they agree, only then these cases who are more than 32 weeks of pregnancy, they can be offered the bedaquiline containing shorter regimen. During lactation, injection containing shorter regimen can be given, but if you want to give bedaquiline, only patients who are ready to use the formula feed, they should be given the bedaquiline containing shorter regimen. Otherwise, it is not to be given. Then the other exclusion is extensive PTB or severe EPTB or children less than 5 years, we have explained above. Then if patient has any intolerance or toxicity to any of the medicine in the shorter MDR-TB regimen, again, we cannot give shorter oral bedaquiline containing regimen. If patient has used the drugs like bedaquiline, levofloxacin, isoniazid, or clofazimine for more than a month, and DHT to these drugs is not available or is resistant, again this patient is out of the shorter bedaquiline containing regimen. Then looking at the DST based criteria, if the DST or DRTB result for FQ is resistant, shorter regimen cannot be given. If there is a presence of both INHA mutation and CAT mutation, again shorter bedaquiline containing regimen cannot be given. So why I am emphasizing on this issue is that if you give it to a wrong person, then this can lead to the failures of the treatment and it can lead to the augmentation of resistance. Just to retreat, we said extensive PTB, which we have already discussed, and severe EPTB. What does it include? Is in adults presence of biliary TB, TB meningitis, or CNS TB. In children under 15 years of age, practically all extrapulmonary TB are treated as a severe extrapulmonary TB, other than lymphadenopathy, which includes peripheral lymph nodes or isolated intestinal mass without any complaint. So in children, all EPTB are taken as severe EPTB disease, other than these two conditions. So we need to keep in mind before we choose shorter regimen for a child. Now to re-emphasize whatever I have been saying, so let us see some field situation whether we can give shorter or not. This will again make the things more clear. So patient has taken fluoroquinolone for more than a month. A second LP report is not available. Can oral shorter regimen be given? Of course, no. Second scenario, patient has INHA mutation. Can shorter oral MDR-TB regimen be given? Of course, yes, because he has only INHA, not both. Patient has HIV with a lymph node. Can we give shorter oral MDR-TB regimen? Yes, because now in the new guideline, HIV with a lymph node with EPTB, which is not severe, we can give it. Patient is 7 years of age. Can we give shorter oral MDR-TB regimen? Yes, because now we can give up to 5 years of age the shorter oral bedaquiline containing. Patient has pyrogenamide resistance on visit from a certified laboratory. Can we give shorter oral bedaquiline containing regimen? No, this is contraindication. Patient has both INH and CATG mutation on the first and LPA. Can we give shorter oral regimen? No, as we discussed earlier. Now, patient is pregnant with 34 weeks pregnancy. Is oral shorter MDR regimen absolutely contraindicated? Because now we talk about pregnancy. Second question is injection shorter MDR regimen absolutely contraindicated? The answer to the first is no, it is not absolutely contraindicated as we discussed in 34 weeks of pregnancy. With mutual discussion with the patient and gynecologist, we can consider it. While injection, it is absolutely contraindicated injection training regimen because they are contraindicated for pregnancy. Patient is 4 years of age. Can we give shorter oral beta-glucan containing regimen? No, because less than 5 years we cannot give beta-glucan. Can we give injection containing shorter oral regimen? Yes, we can give, but one should avoid giving injection. Just imagine you have a son of 4 years of age. Would you like to give injection? Technically speaking, yes, but try to make a regimen where you can avoid injection. Female patient is lactating. Can we give shorter oral regimen? Yes, and in case we are replacing the breastfeeding by formula feed, only then. Can injection shorter regimen be given? Yes, it can be given. There is no contraindication. Adult patient has meningeal TB. Can we give shorter oral or injection containing regimen? No, because meningeal TB comes under the category of severe EPT. 10-year-old child has abdominal TB. Can you give shorter oral or injection containing regimen? Answer is no, because abdominal TB will come under the category of severe EPT. Adult patient has PTB with bilateral cavities. Can shorter oral beta-glucan containing regimen be given? No, because again bilateral cavities they come under the category of the extensive pulmonary TB. So in this case, the final regimen will be we'll give shorter oral beta-glucan containing regimen, and this regimen, as you all know, as per new guideline, is 6 months of beta-glucan. So beta-glucan is given for full 6 months. 4 months of these 6 drugs, which can go up to 6 months in case extension of the intensive phase is required. And these 6 drugs are, so one drug is beta-glucan, of course, then levofloxacin, pyrazinamide, ethambutol, clofazimine, itosinate, and ethionamide. And at the end of 4 months, we will stop INH, itos, and ethionamide, continue with beta-glucan for 2 more months, and after that, next 5 months, we will be giving levofloxacin, pyrazinamide, ethambutol, and clofazimine. So beta-glucan for 6 months, the 6 drugs for 4 months, unless they need to be extended, and the continuation phase of 5 months, wherein we'll give 4 drugs, levofloxacin, Z, E, and clofazimine. And also understand that shorter oral regimen is a package of treatment. It's a package of treatment. All these drugs have to be given, and in case there is any permanent stoppage is required because of the ADR or other reason, or any replacement is required, that is not permitted. You have to switch to the all oral longer regimen. Please keep in mind this very important aspect. And as DDG also told us, now in the initial phase, the shorter oral beta-glucan containing regimen is to be implemented in 7 states, which include Delhi, Maharashtra, Andhra Pradesh, Telangana, Karnataka, Punjab, and Himachal Pradesh. These 7 states we are starting with beta-glucan containing oral regimen, and this will be expanded across the country. And the aim of the country is that within this year we should try to expand this throughout the country. Until this complete coverage, we will continue with the shorter injection containing regimen in these rest of the states. So I hope about the shorter oral beta-glucan containing regimen, we have discussed about the key points, and always be careful. You should give only when it is indicated. Do not give when it is not indicated. Now coming to the case number 3. 17-year-old male patient came with fever and cough for 10. History of ATD intake from June 20 to December 20 based on a positive sputum smear PTB. He was given 2 months of 4 drugs and followed by continuation phase of HRE for 4 months. But patient did not do. Did you notice one thing here? One thing is to be noticed is at the end of 2 months we do not have whether sputum was done or not. Whenever 2 months are completed, we should know whether sputum was done or not and sputum was negative or not. In case it is positive, we should also offer the genotypic test to rule out participation. That is a part of the guideline. And at the end of 6 months, sputum smear was positive. So he failed to this 6 months, which could have been detected at the end of 2 months in case the genotypic test could have been done as per our national guidelines. So national guidelines were not followed in this case. When it comes to us, the first line LP shows INH high level resistance, rifampicin resistance, and second line LP showed fluoroquinolone resistance and the second line injectable to be sensitive. So H resistance, R resistance, and fluoroquinolone resistance, and put-on-immediate DST was available. And you can see the X-ray of June 20 and X-ray of December 20, even the radiologically the patient deteriorated. Let us again go for mutation analysis. For INH, CADG mutation was present, indicating high dose INH cannot be given. INHA mutation was present, indicating even ethionamide cannot be given. So since both the mutations were present, so the high dose INH cannot be given, ethionamide cannot be. Looking at rifampicin mutation, RP mutation was present, indicating rifampicin resistance is there. Looking at fluoroquinolone, in GAIA mute 3B was present, so indicating fluoroquinolones cannot be given, even high dose moxie cannot be given. Looking at second line injectables mutation, both the mutations RRS as well as EIS mutations they were absent, indicating that second line injectables can be given. So the diagnosis with this information is we are dealing with a case of drug sensitive TB treatment failure, who is a pre-XDR PTB because he is fluoroquinolone resistance and moxie high dose cannot be used. Ethionamide also cannot be given because there is an INHA mutation, and DH2 pyrazinamide is not known. So with this knowledge, we'll have to proceed towards the treatment. So let us go back to our, so what regimen we would like to give is, before that we look for the, our same practice of making the, following the principles. So drugs taken by the patient are only the first four first line drugs, rest of the second line drugs patient has not taken. Looking at the DST showing drug sensitivity is only to the second line injectables. Showing drug to be resistance are INH, rifampicin, levofloxacin, moxie high dose, as well as ethionamide, they are all resistant. And rest of the second line drugs, it is still awaited. So drugs not used for DST showing sensitivity are second line injectable. Drugs not used and DST is awaited for all this PAR, bedaquiline, delamide, ibuprofen, all the second line drugs, other than the injectables and fluoroquinolone. Drugs used and DST showing sensitivity. Well, drugs used and DST is not available or is awaited is pyrazinamide and ethambutol. Drugs not used till DST showing resistance are levofloxacin, moxie high dose and ethionamide. Drugs used and DST showing resistance are INH and rifampicin. So with this knowledge of drugs taken, not taken and the DST pattern, these are our preferred drugs. And then third preference, fourth preference. So again, going back to this PMDT 2021 integrated diagnostic algorithm. So since there is a rifampicin resistance, first choice, of course, we move towards the shorter regimen. But here, because both INHA and CADG mutation are there, and also there is FQ resistance is present, so the shorter regimen is out, and we have to go towards the longer oral regimen. So again, same thing. Can we give shorter regimen? No, because of this FQ resistance and both INHA CADG, and we go for the all oral longer regimen. So dear friends, here before we talk about this regimen, let me go back so that just for a revision's sake, as WHO 2020 consolidated guideline, they mentioned group A drugs, that is levofloxacin or moxifloxacin, bedaquiline, linezolid, and all these three to be included in the regimen in all oral longer. From group B, as per WHO suggestion, add one or both, that is clofazimine and cyclosamine. And then there was a group C, wherein the drugs were defined, which are in the decreasing order of usual preference. In case you cannot make a regimen from group A and group B, then we need to choose from group C. As per WHO recommendations, include at least 4 agents from group A and B, which are likely to be effective in the first 6 months, and after that 3. However, in India, the experts, they concur to start with all the 5 drugs of group A and B, that is 3+2, and continue with the 4 drugs in the latter part of the regimen beyond, that is after 6 to 8 months. It was for operational ease in case in the field patient cannot tolerate a drug. Then in the field it becomes difficult to take a decision to stop the drug and replace with other. And what is the regimen? You all know by now, I suppose. 18 months, which can go up to 20 months of levofloxacin, bedaquiline, linezolid, clofazimine, and cyclosamine. Bedaquiline is usually given for 6 months only. Only under some special situations we'll talk about it. It can be given beyond 6 months. Linezolid we give for 600 milligram in the initial 6 months to 8 months, and after that we come down to 300 milligram. And for XGR-TB patients, the duration of longer regimen would be 20 months. And there are some principles of replacement of drugs have been defined in the PMBT 2021 guidelines, which I discussed in my last lecture one month back. But just for retreating, I'll be repeating some of the principles. So at least we should have 4 to 5 drugs in the initial 6 to 8 months, and at least 3 to 4 drugs in the last 12 months. The regimen should preferably be fully oral. However, in certain circumstances, injectables may have to be used for the need of efficacy and side effects. We should have at least 2 group A drugs in the first 6 to 8 months of treatment and continue with 3 to 4 drugs in the final 12 months of treatment. In final 12 months of treatment, if we have 2 drugs from group A and 1 from group B, then only 3 drugs can be given. However, if we have only 1 drug from group A and 2 from group B, then we need to add 1 drug to make it 4 drugs. Also, in case we have only 2 drugs from group A and B, then we also have to add 2 drugs to make it 4 drugs. And the replacement sequence, which has been defined in the PMBT 2021 guidelines, are in the order. First replacement drug to be considered is delamidate. Second is amikacin. Third is pyrazinamide. Next is thionamide. And mind you, they are to be chosen only if they are found to be sensitive. Like here, second-line LP can tell us, here DST by midgets, and here the first-line LP can tell us. So these drugs are to be considered only if we have the DST report with us. Next choice will be PAS. Next will be ethambutol. Then will come PNAM. Delamidate and amikacin will not be started in the final 12 months of treatment. So also keep in mind, the duration of new drugs, that is bedaquiline and delamidate, is limited in majority of cases for 6 months. An extension beyond 6 months can be considered in whom an effective regimen cannot otherwise be designed if only 2 of the 5 drugs are available from group A and B. In group A and B, we have 3 plus 2, 5 drugs. If we have only 2 drugs of these 5, an adequate number of group C drugs are not available due to high background resistance, non-availability or unreliability, and we are not able to make a regimen because of these 2, then we can consider extending bedaquiline and delamidate for more than 6 months. Here, one thing I would like to tell you, although imipenem cilastatin is there in the list of replacement sequence, but it should be used only as a last resort for designing the regimen because of there are operational issues of inserting this PIC line for entire duration, and its cost, and the patient needs to be admitted for inserting this, and the cost of inserting is around 18,000 to 50,000. We have given in many cases in the last 3 to 4 years, but that is, we take it as a last resort. And just to share with you, see, like in this case, the PIC line was there for about 4 months. This patient came from Haridwar in the middle of the night, that it came out, it was bleeding. So at night itself, it was reinserted as the emergency procedure. When the X-ray was done, you can see it going up in the interjugular vein. So these kind of complications, they can be there besides the cost. So do not take it lightly. You decide for the imipenem cilastatin only as a last resort. An individual patient for whom the design of an effective regimen is not possible as per the recommendation, the VPAL regimen can be considered as a last resort under the prevailing ethical standard. So VPAL can be a choice in case we are not able to make the effective regimen as per the current guidelines. As a last resort, we can consider VPAL. Then coming to the replacement of drugs in the sequence in the initial 6 months of treatment. If levofloxacin cannot be used, one should replace with moxifloxacin high dose. If second-line LP suggests that means we give 3B, 3C, 3D are absent, one can give moxifloxacin dose, but also send for the liquid culture. If moxi high dose also cannot be used, then replace with delamidate. We know delamidate is now the first drug in the replacement. If among the 5 drugs, one of the drugs like bedaquiline, linezolid, clofazimine, cycloserine cannot be used, we replace with delamidate. If we find 2 or more drugs cannot be used from group A and group B, that is out of 5, we cannot use 2 or more drugs. We replace with 2 or more drugs respectively from the replacement sequence, which is given to us, which we already discussed, to make it 5 drugs. Now coming to the, very good part in the new guideline is that a table has been given where each and every scenario which can be there in the field that is given. Just to explain, let me just focus on this yellow highlighted area. So in case we have one group A drug cannot be given. Suppose in the group A we cannot give it, then what will be the regimen will be 6 to 8 months of levofloxacin, linezolid, clofazimine, cycloserine, they are already there, and replaced with delamine from the replacement sequence, and followed by 12 months of levofloxacin, linezolid, and clofazimine. So delaminate comes there as a first replacement. Same thing if we cannot give one group B drug, for example, let us say clofazimine cannot be given, then you will give 6 to 8 months of levofloxacin, bedaquiline, linezolid, cycloserine, and replace clofazimine by delaminate. And in the final 12 months of treatment, you will continue with levofloxacin, linezolid, cycloserine because you have two group A drugs. 3 drugs should suffice. Another scenario could be we cannot give one group A and one group B drug. Let us take example of one cannot give fluoroquinolone and clofazimine. So what will be the regimen? 6 to 8 months of bedaquiline, linezolid, cycloserine, and we are replacing fluoroquinolone and linezolid by clofazimine by delaminate, and next drug will be taken. Of course, if it is sensitive. Followed by 12 months of now, after 6 to 8 months, we'll have to stop bedaquiline, we'll have to stop amikacin, we'll have to stop delaminate. So we'll be left only with 2 drugs, linezolid and cycloserine. So we'll have to make 4 drugs by adding pyrazinamide if sensitive, isoniazid if sensitive. So in all this scenario, you see, whenever 2 drugs cannot be given, then you will be choosing delaminate and amikacin if sensitive. And to make 4 drugs in the continuation phase in this scenario, you will have to add pyrazinamide and isoniazid in the final 12 months of treatment. In case you cannot give 2 group A drugs, for example, you cannot give fluoroquinolone, you cannot give bedaquiline, then you will be giving 6 to 8 months of linezolid, clofazimine, cycloserine, and you will replace these 2 drugs by delaminate and amikacin if sensitive, of course. And in the final 12 months of treatment, you will give linezolid, clofazimine, cycloserine, and pyrazine to make it 4 drugs. Again, you cannot give 2 group B drugs. That means both of clofazimine, cycloserine you cannot give. You will be giving levofloxacin, bedaquiline, linezolid, and delaminate amikacin from the replacement sequence. Followed by in the 12 months, because you will be left only with 2 drugs, levofloxacin, linezolid, you will add pyrazinamide and isoniazid in the final 12 months of treatment, provided both of them are sensitive. If you cannot give 3 or more drugs from group A and group B, then what to do? In this case, you will have to give 3 or more drugs from group C. So the remaining drugs from group A and B, whatever you have out of 5, plus 3 to 5 drugs from group C to make a regimen with at least 5 to 6 drugs, which is likely to be effective. If bedaquiline delaminate can be given, then their combined use with at least 4 to 5 drugs, or its extended use beyond 6 months. That should be considered. If we can give bedaquiline and linezolid in this scenario, in the last scenario, one can explore the possibility of using p-pad. That is bedaquiline, pretomanid, and linezolid. So coming back to our case, in our case the issues are age is 17 years, is a case of DSTB treatment failure, pre-XDR PTB, fluoroquinolone resistance, moxie high dose cannot be given, the issue of pyrazinamide is not known, and even isoniazid also cannot be given. So we cannot give any of the fluoroquinolone, including high dose. We cannot give isoniazid. And age is 17 years. Earlier, you know, less than 18 years, bedaquiline could not be given, but now that is not there. So now let us see how we choose the drugs, and this is what we do in our DRTB committee. So first, we always look for, we have 3 drugs in the group A: levofloxacin, bedaquiline, linezolid. So in the group A, first think of levofloxacin. It cannot be given because there is active resistance. We think of moxie high dose, cannot be given because there is a mutation 3B present. So we look for replacement sequence, that is delaminate. Next, we think about bedaquiline. Can we give bedaquiline? Yes, bedaquiline can be given in now up to 5 years of age. So in this case, as per new guideline, we choose bedaquiline. Third group A drug is linezolid. Can it be given? Yes, there is no contraindication, so we choose linezolid. After that, we go for the group B. In the group B, we have clofazimine and cycloserine. Can they be used? Yes, there is no contraindication. We choose both of them. So with this, what we know now, From group A, we cannot give levofloxacin, but we can give bedaquiline and linezolid, so they are chosen. From group B, we can choose clofazimine cycloserine both, we choose both. So we already have 4 drugs. Now looking for the 5th drug. Group C, this is the replacement sequence. Let us go one by one. First replacement sequence is delamanate. Can we give it? Yes, no contraindication. We have chosen delamanate. Amikacin, can we give it? Second line sensitive on second line LP, but not required because we already have 5 drugs. Pyrazinamide, drug, it has been used. DST is not available. Plus, we don't require it, so no. Etonamide, INHA mutation is present. Even if it is required, it cannot be used because there is a INHA mutation present, but not required in our case because we already have the 5 drugs with us. So again, summing it up, from group A, we have bedaquiline linezolid. From group B, we have clofazimine plus cycloserine. And the 5th drug from group C, we have chosen is delamanate. So what is the regimen? 6 to 8 months of bedaquiline to be given for 6 months, extension only if required and subject to certain conditions. Linezolid, clofazimine, cycloserine, and delamanate again for 6 months. And in the final 12 months, we will be giving linezolid, clofazimine, cycloserine, and pyrazinamide if we have a report of it sensitive. So in final 12 months, we had only 3 drugs. So, and only 1 drug from group A. So that was linezolid. So 4th drug is needed. That will be given is pyrazinamide. I hope it is clear that in these cases, how do we go? You see, it's simple mathematics. In case you go follow the principles of treatment, it becomes a simple mathematics. Going to the next case, it is 60-year-old male, known case of severe depression on irregular treatment, presented in December 20 with fever and cough for 2. Never taken treatment before. Diagnosed as PTB on sputum basis, 1 plus BL. Sputum first and LPA, H high dose resistance, rifampicin sensitive resistance. Second and LPA, FQ resistance and SRI sensitive. Audiometry showed bilateral moderate sensorineural hearing loss. What do we get from all this is, he's a 60-year-old male guy, old man, severe depression, and he has bilateral moderate sensorineural hearing loss, besides the pattern of this. Looking at the mutation, KG mutation present, H high dose cannot be given, INHA mutation absent, etonamide can. Rifampicin, RPOB mutation present, rifampicin is resistant. Propion, Guy-Ray, Mu3B, 3C are present, even high dose moxie cannot be given. Second injectables, both mutations are absent, they can be given. Coming back, the issues in our case is shorter MDR regimen is contraindicated. We know why, because FQ is resistance. FQ is resistant, even high dose moxie is also resistance, cannot be given. SRI, although they are sensitive in our case, but they cannot be given because there is deafness and also patient is old, 60 years of age. So we like to avoid this. And cycloserine should be avoided because of severe depression. So in case of severe depression, if possible, we should avoid cycloserine. So we know what are the drugs we should give, what are the drugs which we should not give. So again, the regimen, if we see here, drugs taken nil, the drugs not taken, all the other drugs, drugs showing sensitivity, that is injections, second line drugs, and the etonamide, drugs showing resistance, INS, rifampicin, levofloxacin, high dose moxie, and for the rest of the drugs, it is awaited. Drugs not used and DST showing sensitivity, the injection, second line injections, and etonamide. Drugs not used, DST is awaited for rest of the drugs. Other than these, drugs used and DST showing sensitivity nil. Drugs used because it is not used any drug, DST is awaited nil. Drugs not used, DST showing resistance, INH, rifampicin, levofloxacin, high dose moxie. Drugs used and DST showing resistance nil. So again, coming back to our same sequence, group A, levofloxacin, no. High dose moxie, no, because there is a bit Mu3B, 3B is present. And so think of replacement sequence, we choose delamanate. Next drug in group A is bedaquiline. Can be given, yes, bedaquiline is chosen. Next drug is linezolid. Can be given, yes, so linezolid is chosen. Group B, clofazimine and cycloserine. So we know in this case, clofazimine can be used, but because of severe depression, cycloserine is to be avoided. So we have chosen clofazimine and cycloserine we have not chosen. So again, going back to this, from group A, we cannot use levofloxacin or high dose moxie. We have chosen bedaquiline and linezolid. From group B, we cannot give cycloserine, we have chosen clofazimine. From group C, let us see, this is the replacement sequence, let us go one by one. Delaminate, no contraindication, delaminate 2. Amikacin, again, second injection, although they are sensitive, but not used because of the hearing loss and old age. Z, because DST is not available, although we have not used it, but DST is not there, so we cannot use it. Ethionamide, INHM mutation is absent, so ethionamide can be used. Ethionamide is used for our given. So, from group A, we have chosen bedaquiline and linezolid. Group B, we have chosen clofazimine. So, we are still short of 2 more drugs. So, these are delaminate, but these are in the replacement sequence, but they cannot be used. So, next replacement sequence is ethionamide, and INHM mutation is absent, so it is true. So, the regimen proposed will be 6 to 8 months of bedaquiline for 6 months, linezolid, clofazimine, delaminate for 6 months, and ethionamide. And in the 12 months, we have linezolid, clofazimine, and we need to add 2 drugs, that is ethionamide and pyrazinamide, if sensitive. So we have explained why we have added the 4th drug. So I hope again it is clear. And then we go for the last case of the day, that is case number 5. Because very commonly what I am getting request is that how to treat TB meningitis in cases of MDR TB. But we have picked up one case of the meningitis. So this is a 45-year-old female, known case of PLHIV, who came with fever, vomiting, headache, and altered sensorium for 2 weeks. Past history of DSTB, ATD for 6 months, which was pulmonary TB, from May to November 20. It was on clinical basis and patient. The NCCT of the head showed white matter edema present along with multiple tuberculomas, no history of seizures, and unable to give sputum because the patient had no sputum. And CSF showed the AD levels to be slightly increased, and for CBNet it showed MTB detected, rifampicin. And the pre-treatment evaluation otherwise was within normal. So what we see is there is PLHIV, patient has taken DSTB treatment with PTB, even now there is X-ray abnormalities, but patient doesn't have sputum. No history of seizures. Why? Because we have to be, once we think of cycloserine, we need to know that. And the pre-treatment evaluation is within normal. So the issues are rifampicin resistance, PLHIV, no history of seizures, that is a good thing, and disseminated TB with CNS and peripheral. Can we give shorter regimen? No, because it's contraindicated with and without PLHIV with severe EPTB and disseminated TB, so we cannot give in this case the shorter regimen. So the what we have to think is longer oral regimen, but these are the issues. PLHIV, CNS TB, although no seizure. So if we go through this, patient has taken only the first line drugs. Rest of the drugs patient has not taken. DST showing sensitivity nil because we didn't have any other sample other than CSF on which we had done CBNet. Rifampicin was resistance. To the other drugs it was awaited or not available. So drugs not used DST showing sensitivity nil. Drugs not used DST showing DST is awaited is these drugs. The drugs used but DST showing sensitivity nil. Drugs used DST is awaited is Z and E. Drugs not used DST showing resistance nil. Drugs used DST showing resistance are rifampicin. So before we to make the regimen, in this case, let us see the drugs which can be used in CNS TB. So drugs like levofloxacin, moxifloxacin, ethionamide, cycloserine, linezolid, impenicillin, they penetrate the CNS well. High-dose and pyrazinamide, they can also reach the therapeutic levels in CSF and may be useful if the strains are susceptible. Pas and thimerosal, they do not penetrate the CNS, remember it, and should not be counted as effective agent for MDR treatment. Amikacin and streptomycin, they penetrate CNS in case meninges are inflamed. Little data is unfortunate as of today is about the CNS penetration of very few studies, clofazimine, bedaquiline, and delaminate. So, in nutshell, not good drugs are Pas and thimerosal. Good drugs which can cross blood-brain barrier are levofloxacin, moxifloxacin, cyclosporine, Z, and amikacin. And CNS penetration, limited data about the bedaquiline, delaminate, and clofazimine. And as per PPT guideline, that's why it is suggested that longer oral regimen needs to be modified as per the given. So again, group A levofloxacin can be used, levofloxacin is chosen. Bedaquiline, again you see, although the CSF penetration is not known, but otherwise it's a group A drug. It has good bactericidal activities, good sterilizing activities, so bedaquiline is chosen for this case. Next up in group A is linezolid. It can be used, it is chosen. Group B, we have two clofazimine and cycloserine. Although for clofazimine, the CSF penetration is not known, but otherwise a good sterilizing drug, so we choose clofazimine. Regarding other group B drug, that is cycloserine, it is usually avoided in CNS TB, but it's effective group B drug. There is no history of seizures, no history of depression, so it can be considered under supervision with a good result. Because ultimately our main aim is to use drugs from group A and group B, so cycloserine is chosen. If there is a history of seizures or depression, severe depression, one should avoid cycloserine. So from group A, we have chosen all the three, levofloxacin, bedaquiline, and linezolid. Group B, we have chosen clofazimine and cycloserine. Reasons I've already given. And group C, let us see from group C. Keeping in mind, we have the following fact that efficacy of bedaquiline, clofazimine, delaminate, CNS TB is known. And we are dealing with the case of rifampicin resistance, the CNS TB, which could be life-threatening. And if meninges are inflamed, we know, especially in the early part of the treatment, they are inflamed. Mecacin is a good drug. And there is a no contraindication for mecacin use in our case. So among the drugs in the replacement sequence, instead of delaminate, we are going for amikacin. Because delaminate, the blood-brain barrier crossing is not known, and amikacin could be a good drug. So looking at these, we are choosing group A, levofloxacin, bedaquiline, linezolid. From group B, clofazimine and cycloserine, and group C, amikacin. So the regimen becomes 6 to 8 months, levofloxacin, bedaquiline, linezolid, clofazimine, cycloserine, amikacin. And after the 12 months, levofloxacin, linezolid, clofazimine, and cycloserine. And you see why we have given this chosen basis, because among these we know for bedaquiline and clofazimine, we are not sure of the CSF penetration. And meningitis can be a drug, can be a disease, can be life-threatening. So we want to enforce the regimen by giving the sixth drug, which we have chosen as amikacin. I hope it is clear about the management of meningitis with MDR-TB. So that was the last case. And just to brief you again, which has been discussed earlier, is that this so-called difficult to treat TB clinic, it was initiated by our institute, wherein the difficult cases of drug sensitive and drug sensitive, they could be referred to us and they can get their solution. It was joined and guided by the Central TB division. We had Dr. Sadeva at that time, and now we have Dr. Mandal, who is fully supporting us. And the National Task Force, Dr. Behra was always there to guide us, support us, and Dr. Bhardwaj is equally supporting us. And it was supported by a strong team of WHO across all the states and led by Malik. He has always been there to help us in this. And it's conducted on the Zoom platform with the help of ECO team. The ECO team is really helping us in conducting these sessions. They are all already sitting here with me, and the three of them are there from their IT and their senior people to support this session. And then we had 8 national experts for adult TB and 4 national experts for the pediatric TB. And it is also helping this clinic in capacity building of the districts and the nodal DRTB centers. And now, as DDT informed us, the state level DDTC has been started in many of the states, almost more than 10, 15. And CTD plans to have DDTC in every state to be guided by the national level this clinic. So with this, my last slide, that is the message to carry home, that we must follow the steps to make a regimen. Consider the history of drugs taken and not taken. Look at the DST pattern and the mutation analysis. And we have to make a regimen by combination of the history of the drug intake and the DST pattern. For shorter regimen, I'm emphasizing again, always look for inclusion criteria and exclusion criteria, so that you are starting the regimen in a case where it should be given, not given in a case where it should not be given. And we need to strengthen our laboratory so that we have quality reports in as little time as possible. And the early collection of the lab report and early action will avoid delay in starting or switching to the appropriate regimen. As I said, that always look for the second-hand LP report, especially for the active resistance, so that you don't give the shorter regimen to the person to whom it should not be given. And keep in mind the replacement sequence if it is required. Thank you very much, and I acknowledge our student like Dr. Vikas, my colleague Amitesh, who is also sitting here with me. They really helped in making these slides, and I thank all my DME students, all the senior residents, and all the faculty at NITRD, including our director, Dr. Diwan, for supporting us in this endeavor. Thank you all very much. Thank you.